Welcome to JACC This Week. I'm Harlan Krumholz, Editor-in-Chief of JACC, and this is our issue for September 2nd, 2025. Let's start with the original research. Prevalence and predictors of neurocognitive dysfunction in adults with congenital heart disease. So this week's original research, with Scott Cohen as first author, is reporting the MINDS CHD study, the multi-institutional neurocognitive discovery study in adult congenital heart disease. We're always looking for good papers in congenital heart disease, and we thought this was one of them. This is a prospective multi-center effort carried out between 2020 and 2023 across 14 North American congenital heart disease programs. The team enrolled 467 young adults aged 18 to 30, all with moderate or severely complex congenital heart disease. The diagnostic breakdown was 82 with detransposition of the great arteries, 123 with tetralogy of flow, 132 with single ventricle physiology, and 130 with other moderate or severely complex congenital heart defects. And what did the group look like overall? Well, the mean age was about 25 years, 44% were male, 81% were white, and nearly 80% were in New York Heart Association Functional Class 1. So outwardly doing well. Despite that, cognitive challenges were common. The study used both objective and subjective assessments of cognition. The NIH Toolbox Cognitive Battery, covering memory, executive function, attention, working memory, and processing speed, was included. The NeuroQOL instrument, capturing self-reported issues like memory lapses and difficulty concentrating, was included. A core lab of neuropsychologists reviewed every result, and the team performed deep reviews of the medical records, documenting surgeries, catheterizations, arrhythmias, and so on. So what were the findings? 34% scored at least one standard deviation below the population average on objective testing. 22% reported subjective deficits. Deficits were most common among those with single ventricle physiology, less common in tetralogy of flow and other complex lesions. But it's important to say that this really stretched across all of these conditions. Education emerged as a powerful predictor. Higher education tracked with better cognition. But I wonder, was that part of the testing? New York Heart Association class 2 to 4 predicted some worse objective scores, while higher BMI, atrial arrhythmias, anxiety, and depression were linked to worse self-reported function. What were the implications? Well, for adults with congenital heart disease, the brain must be part of the care equation. Cognitive deficits affect schooling, employment, independence, adherence, and quality of life. Screening and earlier intervention could make a tangible difference. And the explanations were thought to be multifactorial. Biological factors like early cyanosis, multiple bypass runs, arrhythmic burden, psychosocial factors, depression, anxiety, socioeconomic stressors, and protective factors like higher education, which seems to build this cognitive reserve. The take-home, again, caring for the heart also means caring for the mind in congenital cardiology. Next, I want to turn to a state-of-the-art review, the pathophysiologic basis and management of calcific aortic valve stenosis. Desai and Brownwald provide a sweeping review of one of cardiology's great challenges. Calcific aortic valve stenosis is not simply wear and tear. It's an active cell-mediated process with overlaps to atherosclerosis but distinct biology. Early phases involved endothelial injury, lipid deposition and inflammation, and later stages feature osteogenic pathways, leading to calcium nodule formation and obstruction. Clinical progression is heterogeneous. Some patients progress rapidly, others remain stable for years. Despite many attempts, no medical therapy has proven effective. Statins, ACE inhibitors, and anti-inflammatory drugs have all disappointed. Imaging and biomarkers like CT calcium scoring and PET may help identify rapid progressors and refine thresholds for intervention. Timing of valve replacement remains a central question, especially in asymptomatic patients. The take-home of this piece was that calcific aortic stenosis is an active biologically driven disease. We still lack effective drugs, but imaging, biomarkers, and molecular science are getting us closer to predicting progression and guiding us for proper intervention. Next, I'd like to turn to a brief report. Impact of LDL cholesterol when coronary artery calcium score is 0. Look, many clinicians have faced this dilemma. I know I have. A patient with reasonably high LDL cholesterol has a coronary calcium score of 0. Are they still at high risk? Should the calcium score trump the LDL in terms of decisions about statins? Well, Janos and colleagues provide answers with 15 years of follow-up. They report that even in patients with LDL greater than 160 milligrams per deciliter, if the coronary artery calcium score is 0, event rates were extremely low. The risks looked much more like average risk patients than those with markedly elevated LDL. Once coronary artery calcium was detectable, especially if elevated, LDL level mattered much more. The take-home, a coronary calcium score of 0 substantially downgrades risk, even when LDL is high. It doesn't erase the need for lifestyle changes or monitoring, but it suggests atherosclerosis burden should guide therapy intensity, not LDL alone. Another brief report, dietary and lifestyle habits of cardiologists, perception versus practice. Williams and colleagues turned the lens on ourselves with a survey of over 160 U.S. cardiologists. Here's what they found. Diet. 41% often recommended a whole food, plant-based diet to patients, but only 8% follow it themselves. Most eat omnivorous or semi-vegetarian diets. Exercise. 91% counsel patients on physical activity, but only 69% meet guidelines themselves. About half do strength training. Sleep. Average was 6.8 hours a night. I will just tell you as an aside, that surprised me. That seems higher than what I expected. But 1 in 3 were dissatisfied with their sleep. Stress. Half reported resiliency practices like mindfulness, though few had formal training. Social connections. Highly valued, but 2/3 said professional demands made them hard to maintain. And alcohol. Nearly 70% drink, 1/3 weekly. Tobacco use was rare. So the message here was that we promote prevention, but we often struggle with the same lifestyle challenges. And most had no formal training in lifestyle medicine, a gap that could be filled to benefit both physicians and patients. We also feature a viewpoint in this issue, reflections on binary thresholds for hypercholesterolemia and hypertension. McAvoy and colleagues argue that our reliance on binary thresholds like LDL greater than 190, blood pressure greater than 140 oversimplifies risk. Their thesis, cardiovascular risk is continuous, not dichotomous. A patient with an LDL of 189 versus 191 is not really different, nor is someone with a blood pressure 139 versus 141. They argue that binary cutoffs are useful for guidelines and policy, but they misclassify individuals and can lead to both over and under treatment. The authors call for more risk-based, nuanced approaches, integrating continuous variables, absolute risk, and patient context rather than hard cutoffs. It's a provocative reminder that while thresholds are convenient, they may distract from the reality of continuous risk. And if we're really going to get to precision medicine, then we shouldn't be using these simple cutoffs. There's a lot of other good content in the issue, a leadership page on reclaiming agency through non-clinical competencies, skills beyond medicine that shape leadership, a really great Amara yacht image, a beautiful anatomic illustration of the right atrium and left ventricular interior. And from across the JACC journals, we bring in case reports and perspectives, which I know you'll find useful. Well, that's it for this issue of JACC. I hope you've enjoyed it. And until next time, stay curious.